welcome to the 8th and final lecture in the series we're calling Current Issues in Bioethics. We will have another 8 for next year, and if you happen to be in the city, you can come back for those. Be another 8 different lecturers. And if you're not in the city next year when we're doing this again, you can do what some people are doing perhaps today, which is watching through the web streaming. And to any who are watching through YouTube or web streaming, we welcome you as well. We have today with us Dr. Brian Carter from Children's Mercy Hospital here in Kansas City. He is a colleague of ours, not only in the clinical world, but specifically in bioethics. Brian serves as faculty at the Center for Pediatric Bioethics at Children's Mercy. He teaches in the certificate in pediatric bioethics, which I believe is the only such certificate program in the world.
It's the only pediatric one, yeah.
In pediatrics, yeah. We have others, including one that we have that's on hiatus for right now. And Dr. Carter has a distinction of having co-authored a book on pediatric bioethics that I think is the book in pediatric bioethics. He also was at the forefront of the palliative care movement in pediatrics, and will be talking to us today about complex care with compassion medical technology in pediatric palliative care. Dr. Carter is also someone who is a father and goes at the practice of medicine with children and their parents from experience of having been and being a father, and that makes a difference perhaps. Whatever it is that makes a difference, he is a phenomenal clinician and bioethicist and colleague, and we are delighted and honored to have you come and address us today.
Thank you, Terry. Is this mic on? Yeah, okay, thanks. And thank you all for your attention and the invitation to be here. Today we're going to talk about technology, and I hope it doesn't let you down. I'm not going to talk about ventilators and dialysis machines and how they work and why we use them. I want to engage you in a little bit more discourse, if you're willing, and certainly reflection in trying to understand the impact that technology has had on healthcare as it pertains to pediatric palliative care and perhaps even more broadly to all aspects of medicine. So what I'd like to walk you through is these 3 key components. First, to address the need for technology, because I don't think I would be standing in front of you with a microphone on my lapel and some of you out there in the interweb world watching through a virtual means if it weren't for technology. So technology actually enhances education, as you know, and it's resulted in many, many wonderful things. Inclusive for pediatrics, it's certainly enhanced the survival of many illnesses for children, so that these children have survived despite life-threatening conditions. And in my own bailiwick as a neonatologist, I absolutely rely on technology on a day-to-day basis. So we now have living amongst us, and perhaps you yourselves or you know others in your families and in your other spheres of connection, of children living with what we may have labeled in the past disability or other abilities that would not have survived years ago, and some of those children may be technology dependent, and we'll talk a little bit about that today. But medical technology certainly is part and parcel to how we sustain many of life's basic functions, especially in the intensive care unit, whether that's breathing or eating or moving or eliminating. And that is something I'd like you to think about throughout this presentation. Secondly, I'd like to talk about the impact that technology has had on healthcare, but also on patients' lives and their families' lives. I won't give specific address to the healthcare marketplace and the cost of such care, especially when attached to apparatus technology, but I'll leave you to meander through those thoughts on your own and to explore the literature and through your own education and practices, perhaps be able to distill what might be a rational use of technology despite its costs, or perhaps preclude the use of certain technologies because of their cost. Thirdly, I would suggest that technology, as everything else on this planet, has limits. And we have tried to outstrip or leave those limits behind often, and some might describe the current practice of healthcare as one that seems unbounded and without limit, and we just keep pressing the envelope and going further and perhaps onto uncharted waters that can be dangerous. So I like that navigational alliteration because I'm the son of a sailor. My dad was in the Navy for 42 years, and I was born in San Diego and grew up all over this wonderful country. And I was pulled in years past to reading Homer's epic poem, The Odyssey. Anybody familiar with that? College literature, anybody? Classics. So the story of Odysseus is that he's coming back from Troy, having been involved in the Peloponnesian Wars, and they were victories, and they were on their way back to Greece. And you had to go past this certain island where there were these creatures that sang beautiful music and drew your attention, if you were a sailor, to steer your craft directly towards the shoals in which you would have your ship wrecked. And you would die, all because you were so enamored by the sounds of the sirens. Now, Homer describes Odysseus as doing something rather dramatic in anticipation of this. Anybody want to chip in and tell me what he did? What did Odysseus have his sailors do to him? Tie him to the mast of the boat. Why? Because he was the captain of the ship, and he could have decided to ask them to steer the ship towards the rocks, towards the sirens, and they would all lose their lives. He also put beeswax in his sailors' ears so that they would not be lured by the siren sounds of these creatures. And he made them swear an oath that at the point of sword, they would hold him to the mast if he were to somehow or another wrestle free and try to go towards the sirens. So this is what affectionately today is known as an Odysseus contract, making bounding contracts that prohibit us from doing things that we know aren't in our collective or ultimate best interest. That term is popular in psychiatry. The term dynamic inconsistency is popular in economic psychology, and trying to avoid future harm by taking certain actions, whether it's with your portfolio or with certain other life goals, and orienting the way you use your time and your resources to have something left for a rainy day instead of spending it all now. I think my bias through this talk, you'll certainly hear, is that we have to act in advance of certain circumstances to protect ourselves from the potential harm of being too easily persuaded to give in to certain future temptations. Now, you might know what those are for yourselves as an individual in your own personal lives, but I would argue that this also exists for physicians, especially intensivists, as we consider the employ of technology. So by constraining himself Odysseus actually achieved what would be described as a better outcome than might immediately have been apparent had he not taken certain actions. And I ask the question here, can a future tethered to technology seem so natural to me as a provider in the ICU? It's basically an extension of what I do every day, and so if somebody goes home attached to technology, I don't give much thought to it. Has it become so normative that not pursuing such technology dependence would be unimaginable? Why would I raise this? Because there are consequences, there are costs attendant to technology, and we'll work through those. Neil Postman, who's a social critic and author, wrote a wonderful book in the 80s called Amusing Ourselves to Death. It was basically about the advance of communication techniques and television at the time. It presaged computers, and how we continue to entertain ourselves with oral legends and then written word and then radio and then television, and now you can add to that internet, etc. And the story goes that we're all subject to the lures of entertainment. He also wrote a book in the early 90s on how technology has changed our very culture and how it's become the driver as opposed to the respondent to culture. He uses words like we succumb to its nuances and hidden meanings. Anybody have one of these handy? Can't distance yourself from it? I just lost my life. Yeah, I'm distractible with one of these too. And so I can become victim to the tyranny of the urgent by having these communication devices constantly nagging at me or freely at my disposal for me to divert my attention to. But what Postman says is that embedded in every tool, every apparatus technology that you can imagine, is an ideologic basis, a bias basically that predisposes us to build a world around one model where these things are normative as opposed to another model where they're not. So in the ICU, it's normative to have ventilators, to have ECMO at our disposal, to do all sorts of gee whiz golly, sexy, great, cool surgery stuff, to think about medications that might have been unheard of as recently as 10 or 20 years ago and employ them without attention to cost of any nature other than maybe an adverse effect in combination with the medication the patient's already on. So the idea of using technology basically biases us to a world with it, and that's different from a world without it. The first 10 years of my practice in neonatology, I did not practice in ECMO centers. I occasionally would send a baby to a distant center to receive the benefits of extracorporeal membrane oxygenation. But believe me, I took care of thousands of babies that lived without it. I didn't need ECMO except maybe 3 or 4 times a year. But if you're in an ECMO center, everybody needs ECMO, or at least it's on the list of things we ought to try before we let you die, and it shapes the way we think. The same can be said in the developing world without many of the resources and apparatus technology we have in how it's applied to different category patients, different diagnostic and age groups. So Postman offers this thought about technology, and then he says, the way it's dramatically impacted society is such that it's central to how you define yourself and how you think of your world. So once again, think about a world without clocks. Most of you don't wear wristwatches, but you might pay attention to a clock on the wall or a clock on your iPhone or the small corner of your laptop or tablet device where you can occasionally glance at the time. think of a world without reference to time other than the dawning and the setting of the sun. I have a daughter currently in Ecuador, and with the limited things that the people she lives with have, the life has been turned upside down by what they all of a sudden don't have. Imagine that world as your norm. So the way we define society is contingent upon the technology we use. I mean, if you're the president, you've got a military at your disposal. Gulf War veteran here. Yeah, there's a lot of technology wrapped up in the military. If you're the director of public health, you've got a lot of things to worry about. But one of those things is pandemics or epidemics in which there's a mass call for the need of ventilators because you've got bird flu or you name the condition that's going to take a respiratory toll on a large number of the society, and yet ventilators are limited resources. So we describe our society perhaps as a technocracy, but Postman invites us to go one step further. He claims that the United States is the only such culture to become this, but he uses the term technopoly, a society that replaces and redefines the concepts based on its belief in technology. Technology is the be-all, the end-all, it's the cure, it's the solution. It actually becomes the premise for moral decision-making. If we have the technology, we must use it. That's what we call the technologic imperative, and maybe we should move into discussing that. Now, I remember the first landing on the moon, and I remember all of the excitement around that. And at the time, I wasn't paying attention to this. The Harvard program on technology and society that was funded by IBM, Big Blue used to be a big player like Google is now, to the tune of multiple millions of dollars, argued this: technological innovation exhibits a distinct tendency to work for the general welfare in the long run. Now, most of us would say, sure. But you have to remember, man going to the moon in the late 60s, which was a tumultuous decade in this country, and we were ever more cognizant of world hunger, population dynamics, and growth, and we hadn't even encountered all of the information technology that you're so familiar with now, and we wanted to believe this. Oh, so what is the derivative, trickle-down benefit of sending people to the moon? And people pointed to plastics and how a car's grill was made and how high-impact plastic, something you take for granted every day, was a byproduct of this. And so many other derivative things. We might even be inclined to believe this still. We think that technology can be the solution to all of our problems and might point to past examples to really address that. But this observant philosopher from the University of Oslo in Norway published a paper in 2002 that I think draws our attention to what technology has left us with. There is, in Hoffman's argument, a technologic imperative, a must-use phenomena, based upon the possibility and action that technology brings. It's possible, therefore we have to do it. There is an imperative for commitment that I've made to my patient, and once I've got on the treatment train, I will stop at nothing to try to cure him. And I'll pull out all of the stops and employ every imaginable apparatus technology to accomplish the goal of saving a life. There's an imperative of procedure that says, technology is hard stuff and you have to learn how to use it. You have to apply it in certain procedural ways. Do you know how to use that right? Oh, let's set up the schooling. Let's have competencies. Let's employ the technology, but make sure we're smart in the procedural process. There's an imperative of demand. We live in a very informed public where people come asking for MRI scans or monoclonal antibody treatments or the next phase new age drug that's seen on television or your iPhone or your tablet. We have an imperative of the unknown. Will this work? I don't know. We haven't tried it. Let's try it and see what happens. That's the innovative dimension of the intensivist and the surgeon. The imperative of means as ends to itself. We basically seek a technological fix, so if I employ technology, I must be doing the right thing. Oh, there's a patient involved? Well, that's okay. We're learning how to use this technology. And besides, everything else that's helpful has been a derivative of technology, so let's just hope for the best. And so we implement it, we proliferate technology, and ultimately, we inappropriately use technology sometimes. And it takes a little bit of moral courage to admit to that, let alone talk about it in public. Technology, by the way, and Hoffman makes these points in his paper, is applied oftentimes unsuccessfully. We employ it in the wrong circumstance, and so we don't get the result we were looking for. Technology may also be used in an unkind manner. We might apply technology to prolong life that is of such insufficient quality that we wouldn't, if we stopped to think about it, really want to prolong that life or just prolong the dying process. But has anybody heard of that, end of life in an ICU tethered to technology? How long are we going to do this? We apply it unsafely, where it's not been tried before, just to see what happens. We may or may not anticipate the consequences. We employ it unwisely when, again, perhaps in a resource utilization sense at a broader societal level, we are diverting resources to gee whiz golly technology instead of some fundamental basics that might help a larger population. So we get into the utility of technology arguments. Technology may be employed also when it's unwanted. When a patient has said, I don't want a resuscitation, and we resuscitate anyway, place the patient on the ventilator, start to dialyze them, and then step back a few days later and try to determine if we did the right thing. And recently in a paper in the Journal of Medicine and Philosophy, a philosopher from Auburn University states that ultimately all technology limps. I couldn't help but use that phrase. It just conveys such an image. So we can do a lot of things and cure a lot of things and restore functions with technology. There's some limits to technology, but they're often overcome if we just give it time and enough hard work. And most of the things that we do in healthcare can be treated with medicine, surgery, technology, supported to the point that some restorative function is the goal. And even if it's painful, we can treat pain pretty well. But at some point, all technology limps. None of us make it off the planet alive. Simple fact. Doctors. So the Technologists' Siren song, while it appeals to us, the technology might be something in which we find great comfort and easy access as it's all around us. It also confounds us. We can't look to technology and see that it's always done generally good things for the welfare of the populace. So we'll visit a few things, and Stanley Reiser had in particular addressed the issue of the artificial respirator, and in the intensive care nursery, we use them every day. So we end up sending babies home sometimes dependent on a ventilator. with a tracheostomy, training parents, having nursing in the home, hopefully to see the child ultimately decannulated from the tracheostomy and off the ventilator, but it might take 2, 3, 7 years, or maybe it's impossible, because maybe we put the wrong patient on the ventilator. Someone with life-limiting genetic condition, someone with anoxic encephalopathy, somebody with an undiagnosed but lethal or prematurely lethal condition that we're only learning about, and we've propped up life with all this apparatus technology, very hopeful, employing it with great expectation, but really unknowingly. And so technology dependency is common in pediatric practice. Now, a respected pediatrician and ethicist, Chris Feutner at Children's Hospital of Philadelphia, wrote this paper before he moved from Seattle in 2005, in which he studied technology dependence at a children's hospital, Seattle Children's, cohort of 100 randomly sampled pediatric inpatients. Let's go look at 100 kids going home and see how often they're technology dependent. And you can see the data there on the slide. A lot of them were, 40-some-odd%. And they were dependent upon devices. A G-tube is technology. Drugs for asthma, BPD, seizures, insulin are the derivative products of technology, especially if you've got an insulin pump. Anybody in the room with an insulin pump? So you know what I'm speaking of, and some of these patients had both. The median number of prescribed medications was 2. Now, this is over 10 years ago. I bet if I did this down the street at Children's Mercy today, 100 random discharges, the numbers would be as glaring, if not more so. Because I see kids in the follow-up clinic from the neonatal ICU the first couple of years they're home, and easily many of them are on 2 if we include multiple vitamins and iron, or their Flovent or albuterol for the respiratory disease, or their anticonvulsant, or their Lasix. I have kids on 5 or 6 medicines come back to see me. So I think these numbers have only expanded. Now what Feutner did, and I think this was very cunning, it's actually very bright, very smart. Chris is a wonderful guy. I'd read anything he writes and think about it seriously. He suggested that at the time, in 2005, because the only reference for defining what technology dependence was a 1987 publication by the Office of Technology Assessment. That's an office created by Congress to go study what we do in our society. And they categorized 4 major groups, as you see here. Chris actually got very smart and said, you know, it's more than those definitions. If we define technology dependence as a situation in which if you took something away from the child and he or she got ill or had to go to hospital or died, that's a sufficient definition for technology dependence. So all of a sudden, insulin is technology dependence, no qualms. Not just the home ventilator, but perhaps oxygen of any form, dialysis certainly. So I put together this slide. The cartoons are mine. Chris isn't that funny a guy. But just to drive the point home, so if you're technology dependent and we're defining technology dependence as what happens when technology fails, the child is harmed, let's go through some failure consequences. Well, if all of a sudden your technology fails and you feel like you've got a fever and you're home ill, that's one thing, but if technology fails and it results in death, that's something altogether different, right? Failure, is it likely? Well, with a pair of crutches, no. But anybody cared for a baby with cerebral spinal fluid shunt? Babies with meningomyelocele that require shunting in the first month of life for their corresponding hydrocephalus have as many as 6 revisions in the first year of life. Each of those is following on debilitation, nausea, vomiting, lethargy, discomfort, or perhaps, albeit they're young infants, the risk of herniation. What if things aren't maintained well? Well, if you spill a bottle of pills, you can go refill it, right? But what if your machine fails? You name the machine: home dialysis, feeding pump, ventilator, CPAP device, oxygen tank runs empty. What if the failure results in no significant hindrance or makes you bedbound? How burdensome is your technology? Oh, I can put up with it every day. I take 3 pills in the morning. That's not a problem. If I run out, I'll call the doctor and get a refill. Well, it might be very burdensome if you're tethered to, again, a large piece of apparatus technology like a dialysis unit or a ventilator. How reliable is the system? Meter dose inhalers, pretty reliable. Sometimes fail, but not with terrible consequences. What about dialysis machines? Very reliable at the dialysis center. If you're using home peritoneal dialysis, there's a little bit more in the way of glitches. And how about costs? Anybody? Or consensus on the appropriate use and employ of technology? So Feudner put together this presentation of technology dependence to drive home a point. In pediatric healthcare, we have to become familiar with this. It's part of the landscape. And we ought to think about how we use technology, be it in curative or palliative domains. So the point of this cartoon is to remind you there's a patient in there somewhere, even though the first thing that garners your attention is all of the technology. The ventilator. Iron lungs, 1950s polio epidemics. You might think that's just of historic value, but it presaged with negative ventilation what became the common mode of positive pressure ventilation used today in so many more devices, including, see if I do this right. Well, obviously not. Including a little ventilator in the middle up there that has the digital screen. That's a home ventilator. It's not much bigger than a coffee pot. And that is a wonderful piece of apparatus made available only because of extreme technologic advance. Now, I didn't work with iron lungs, but when I started in neonatal practice, we still used what was called the baby bird ventilator, and being a military-trained guy, we learned how to field strip a baby bird ventilator and put it back together. That was part of an Army intern in pediatrics responsibility. And that ventilator had no synchronization. It just pushed air into the patient, whether he or she was breathing in or out. Oops, that's too bad. We're just going to ride herd over your respiratory drive and push air in. Synchronization of ventilation, the simple synchronization between the patient's respiratory drive and the machine's set drive, originally was a byproduct of a little inflection device put at the costophrenic angle. And when you start to breathe, there's motion detected, and the signal went back to the machine, and it was originally an air tube hooked up to a pressure manometer. Pretty old school, but boy, were we glad to see those in the 80s. And then microprocessors came around, and by the end of the decade of the 90s, we had microprocessors that allowed flow detection, the difference in the airflow at the level of the endotracheal tube, either deep or at the connection with the ventilator. So sensing airflow differences. You know what we do now? Across the street over at Children's Mercy, we use something called neurally adjusted ventilatory assist. Some bright doctor and engineer said, what if I put an esophageal probe in and it detects the electric signal from respiratory drive, phrenic nerve to the diaphragm, and millivolts of electrical signal can, within milliseconds, synchronize the patient's respiratory drive to drive the ventilator. It's slick. It is great technology. Why? Because we hurt the lungs less. The patient's really driving ventilation. And it's only now creeping into pediatric and adult medicine. So the ventilator's got a storied history, from these old machines to this new Nava stuff. And I think that, countless lives, millions of lives have been saved by the ventilator. Here you see one of my colleagues, Winston Menimtum, on the bottom corner there with one of our home trach vent patients. If you're a preemie born at 23 to 28 weeks and you have bad enough lung disease and you might need a trach and you might go home on assisted ventilation, you can pretty much count on being decannulated and off the ventilator by 2, maybe 3 years at the longest. So putting up with home ventilation for a couple of years to see survival might be a very valued thing. But if, on the other hand, you're a term baby with anoxic encephalopathy and you have no relational capacity, very meager respiratory drive, weak or hypertonic musculature, and you need to be on a ventilator or you'll die, we can put a trach in you and we can attach you to a ventilator and you'll stay alive for a while. But you can't anticipate the duration. You can't plan on 2 or 3 years and everything's going to be fine, because all the ventilator's doing is propping up life without changing the quality of that life. And the developmental potential has already been hindered by the disease. So what's the appropriate use of the ventilator? Should we let any and everybody have it? Should we parse out differences? What ethical rules do we employ? Principles, values? How do we pursue this in open dialogue with our colleagues? Because the guys and gals that work in the home vent clinic, it's pretty much second nature. Now, they'll come in the ICU and say, we don't recommend that this action be taken. But how are we going to rein in the inclination to employ technology from an informed public who says, I know you've got this clinic, I visited your website, you can help my child? Debate along these lines has carried on across the pond in the UK, where people are wondering about the employ of assisted ventilation devices for children with spinal muscular atrophy, Wernicke-Hoffman's disease, where essentially you by nature have polio, not because of a polio virus, but because you've got anterior horn cell disease. And these children are wonderful, engaging children from the neck up. Smiling, engaging faces, actually attentive. They have great cognitive capacity, but they're paralyzed essentially from the waist down. Is it appropriate to provide tracheostomy and home ventilation for this patient who will never, literally never, improve? Big debate, lots of things to consider. What do parents say about being on the receiving end, a child of theirs now having a trach and assisted ventilation? I've got a couple of slides of parent outcomes that will be important for you to listen to or look at. Interestingly, they come from Australia, not from the States. So these families basically describe the change in their world at different levels and their experiences and what they mean and how they've had to act differently from first receiving the diagnosis that their child would need such support, then having the tracheostomy, learning how to use the ventilator, ultimately going home, and how it changed life and the expectations of life at home. Graphically, some of us think more graphically than textually. Basically starting at point 1 in the hospital, going through multiple changes over time at different levels that transforms what it means to be a parent, what it means to have relationships in the home, how the whole dynamic of parenting has changed. The black and white picture from the Saturday Evening Post there shows the first pediatric external pacing device. Now they're the small bottom right corner, smaller than the palm of the child's hand, not my hand. And they're implanted internally, as you know. You also see there ECMO at the top with the tubes coming out of the child's neck. The child is attached to a ventilator, but some children and adults on ECMO now are no longer attached to the ventilator. In fact, some are even ambulatory while attached to ECMO. And the contraption next to the girl with the ECMO tubes is the ECMO circuit, in which you might find the 7-pound baby that we're caring for if you look hard enough. There in the middle is a doll. The doll actually is talking about the heart, and blood goes in, gets oxygenated, goes round and round, comes out, all on a machine, or with, you see here, the Berlin heart, ventricular assist devices. So we've got a lot of potential for how we treat cardiac disease. And some of the work I do is in our fetal health center, counseling families when prenatal diagnoses reveals a likely complex congenital heart disease. One of those diseases is hypoplastic left heart syndrome. And so in one year, I just took a look to see how many patients we had that had hypoplastic left heart syndrome that were seen by neonatology and cardiology. 26 patients in 2013. 73% were diagnosed prenatally. That's about standard across the country. No more than 70 to 80% are diagnosed prenatally. There was one intrauterine fetal demise and 2 patients who elected pregnancy termination, resulting in 23 patients that were born. Some of those, however, were born without prenatal diagnosis, and the condition was an absolute surprise. So imagine having not known and being told on the forefront that your child needs 3 staged surgical palliative operations because you're going to change an inadequate 2-chambered heart into a single ventricle heart to sustain life, and each stage has its accompanying morbidity and mortality. And it might be daunting, and it might lead you as a parent to say, I don't know if that's the right thing for us or for our child. Or if you found out prenatally and you had X number of months to learn, explore, and consider and talk to other people, you may be inclined, but not necessarily. So about 1/4 of the patients who had prenatal diagnoses elected not to pursue surgery, and half of the patients who were diagnosed postnatally elected not to have the surgery. But we can do it. And it might even be advertised as a 70% net survival over the course of 4 years and 3 surgeries. Should we do it? What makes it right? Not the technology, but the ascertainment of appropriate use of the technology. Technology, if we go back to the imperative slide, doesn't have a moral imperative for use. It really only steers us towards a moral imperative for ascertainment and appropriate use. The technology in and of itself is amoral. It's a thing, but we have to think about its appropriate use. And dialysis, Brad Wardy is internationally renowned and has saved many children's lives with chronic kidney disease. But again, from Australia, a parent's perspective, and I found this paper so impactful that I shared it with my nephrology colleagues, and now it's normative before any young infant actually goes on dialysis, that we use this slide to describe the 4 major domains as related by parents in Australia from children who are dialysis dependent. There's this process at the top there, absorbing the clinical environment. What's it like now to be on dialysis in the hospital and transferring my patient, my son, my daughter, home and having dialysis in the home. There's all sorts of issues raised about trust, invasiveness, losing ownership. One of the things that happens when you go back to Postman's statement about this inherent bias, the ideology behind the appropriate use of technology, is that we concede some of our autonomy. We give up some of our own control to an apparatus technology, and hopefully to somebody, clinician, who's going to be pretty smart and sensitive about the use of it. Because I'm not in control anymore of raising my child without that attendant piece of technology and somebody's input about how to make adjustments and fix it. That's a challenge for parents. In fact, the next challenge they notice here at about the 3 o'clock level on, if you pretend this is a clock face, is the medicalization of parenting. And I remember when this really happened. Terry, you may as well. It was really about 1990 to 94. We call it the managed care era, when it became normative to expect parents to provide an element of care at home that previous to that point in time in history was only provided in the hospital. So people started to go home, not just with a G-tube, but a G-tube and pump feedings over 8 hours at night. Not just with oxygen, but with oxygen as CPAP device. Not with just antibiotics, but PICC lines and home infusion therapy companies. They didn't exist in the 80s. So we can push you out of the hospital, and this care can be done at home, and it's perfectly normal to expect that element of care to be provided by parents. They'd do it for their children, wouldn't they? What kind of parent are you if you wouldn't? You see the inherent bias, the ideology about the technology in that illustration? Parents also complained of coping strategies and the need for support structures. If you think you got marital problems before you have a child dependent on technology, before you have a child, wait till you have one home who's absolutely dependent on one of you all of the time being accessible and responding to whatever needs come up with their technology. It disrupts the home and causes spousal dependency, sibling neglect, the other kids, decisions whether or not you should do certain things socially. And what happens if ultimately your child succumbs to his or her disease or the technology fails? There might be discourse about enough is enough already. No, we don't want an autopsy. No, we don't want to donate. We've had our share, our fill of health care and all of this business. Or one spouse may feel that way and the other, oh, but we've been on the receiving end and it's helped us so much, we have to give back to the broader society. I want to donate. So you can see how different things are introduced by technology. My colleague John and Brad Wardy wrote a paper about this unique to the pediatric dialysis and nephrology situation if you're inclined to want to read more. So in the end, how do we try to decide the appropriate use of technology or not? We consider what we can do, we consider what's been done and what parents reflect upon. And just because something's possible doesn't necessarily mean it's right. So having been influenced by this document growing up, I return to it because some 30 years later, it's still pertinent. It still helps people have the discussion about obligatory or non-obligatory treatment and whether you're risk attendant, risk averse, risk tolerant, and whether or not you have those discussions with families to learn about their risks as well. There's a lot of other literature. I think you have the slides at your disposal, so I'll just plow through a few slides to the end. A lot from the nursing literature, interesting from the nursing literature, not from the physician literature. Some of this work from the states. It impacts cognitive and environmental senses of what's normal. Parents use the term, we've sort of become accustomed to the new normal that life is with this piece of technology. Role confusion, I've already alluded to at the bottom there. I stole this graphic from the New England Journal last year or two, and really the intention was to demonstrate that when a patient is admitted, now this is to an adult ICU, that even the technology that's employed from day one until the time the patient dies is increased, and that's the red colored bar there. You can see the curative care that's increased. More and more technology being applied, and only lately is palliative care introduced. So even in adult medicine, and I dare say this happens in pediatric ICUs as well, though I question that for the audience, there's a great inclination to employ technology, even in a terminal hospital admission. And the argument that I make for palliative care in the ICU is that it needs to be concurrent with the cure-oriented care and not wait until we decide to stop the cure-oriented care. So finally, I think technology dependence is what I would describe as a liminal space. That is a threshold, a space between. Okay, let's make that more clear. I'm standing in this space. Imagine it's outside the room, and I'm going to walk across the threshold of the doorway, and now I'm in this space. Let's say I'm in a different room, right? The room I was in before may reflect my prior state of health. This might reflect my future state of health. But while I'm in that liminal space, that threshold, that doorway, I'm neither as healthy as I was, nor do I necessarily know how healthy I'll be if indeed I survive. I'm struggling in this liminal space. It's the space where palliative care has a lot to offer. It's also a space that's occupied with technology-dependent children. I'm not as healthy as I was before I was dependent on this, and I don't know if I'm going to survive. Or if I do survive, it's going to be totally different than it was in that place. In this liminal space, help me. Help me with the appropriate use of technology, the changes that it makes on my life, and how I might approach a future that's uncertain. I'm going to close with a quote from one of our students in the certificate course, unsolicited. One of the weeks that we have in our 9-month course, 26 or so topical weeks, is about technology and complex care. And so Kirsten Herney's a physician. She's a med-peds resident who graduates in a month or two. And her closing remarks on the week's discourse, about 100 different things on a discussion board over the course of a week, was, I thought, so summative that I couldn't say it better. Technology has allowed for miracles beyond our wildest dreams, but at the cost of much unnecessary suffering, and in her words, some dimension of futility. Palliative care is the recognition of humanity in the midst of science. It's going the extra step, as she says, like when you're preparing for rounds. Looking at the patient before and see the sweat on their brow, the grimace on their face, the loved ones in the chair beside the hospital bed holding their hand. Not just paying attention to the data on the numbers from the labs or the images. It's not just the end of life. It's not just comfort care. It's comprehensive care. It's putting care in the context of the whole person. Sometimes the miraculous technology is so tempting that it's taken out of this context and applied to situations where it doesn't belong. Sometimes we get so excited about our miraculous technology that we forget that medicine is the marriage of science and humanity. Science is the easy part. Well, not necessarily easy. Talking to students, student of life here myself, it's not always easy. But humanity is always there. And palliative care happens when we recognize that. Thanks for an opportunity to share and hopefully get you thinking about a few things this morning. I'm happy to address questions if there are any.